you. So I will continue within the same frame, and now I would like to highlight the fact that we do have the same liposomes, but this is the structure of the near-infrared lipid that we are adding, and in here we are going to study the release of doxorubicin. So we have identified the mechanism with topotecan. We have identified the release with topotecan because it was a clear label, fluorescent drug to monitor. Now, can we do the same with doxorubicin? We obtained the doxorubicin release with incubation. Here we have 50% serum. We can see the release. We can see some ligands. This is a little bit more than the topotecan, but I'm sure that there are methods to be controlled. And we have tested our particles now for MRI properties and thermal release using the Exablade system at what is a place. And we have prepared a gel in the format of a 96 well, and we controlled the temperature in each well. See, this is something with like the focal point. And we have identified the release of the liposomes within this focal point. And we can see the contrast enhancement coming from the gadolinium microcycle lipid. So we have done a number of in vitro studies to confirm that the liposomes behave properly from MRI properties as well as for release properties. Again, the doxorubicin and different buffers at different temperatures, so we can see the very rapid release at high temperature and very low release at 37 degrees. And we applied that system with a therapy and imaging probe system from Philips. This is and we applied thermocouples to monitor the temperature during the exposures to the focus ultrasound. Again, similar to the topotecan story. Application, this is a representative image of 6 animals. So we can see here that this type of wedge, this type of color, blue and red, corresponds to the filter of doxorubicin, whereas this type of wedge corresponds to the filter for the near-infrared lipid, which is part of the liposome. So we can see that after every insonation, we do observe a release of the drug. So this was very hard to observe. And we do see an accumulation of the liposomes in the tumor. We do also observe, in some of the cases, some small leakage through the blood vessels here, indicating that the enhanced EPR effect is not becoming only super enhanced when we apply focus ultrasound, but we have also an enhanced release from the blood vessels. But we can observe that the liposome, the lipid at least, is remaining in the tumor for several days, although the doxorubicin is rapidly clearing out. If we want to compare if we want to see the left and right tumor, the difference in the near-infrared brightness, we can see that in all cases we have an enhanced accumulation of liposomal and of liposomal drugs, in this case liposomal doxorubicin. So in other words, I mean, focus ultrasound-induced hyperthermia enhances accumulation of particles in the tumor, particles and drugs. Now, we did an efficacy studies using doxorubicin, MDA, MB2 breast cancer cells, triple negative cells, and then we have applied a slightly different protocol because our colleagues are introducing the concept of heating before injection, and we combine it with heating after injection. So in other words, we try to monitor, to control the accumulation. And this is what is happening. So we have the node drugs. This is a guy where its tumor has been practically gone, I mean, in this case. And it occurs after 2 treatments with focus ultrasound. We do see an effect of the drug, of course. I mean, but it is in the case of focus ultrasound treatments, exposures, this effect becomes significantly higher. And we did histology sections, and just to identify that with the focus ultrasound and drug, here is not drug, no focus ultrasound, we do see a clear effect on dead cells and necrotic tissues. Okay, this is working nicely with liposomes, but what about some other drugs, some other therapeutics? Okay. What about antibodies? And there are some aspects, there are some efforts to enhance the delivery of antibodies in tumors or through the brain. What we have done, we have used again the near-infrared tool, the optical imaging tool, and we have labeled Herceptin trastuzumab became a very stable antibody after labeling. The label is not going. We tested that, and we administered in mice. And this is the accumulation of the antibody in the tumors without a focus ultrasound. With one treatment of the focus ultrasound, one exposure on the right-hand tumor, and this is after 3 times exposure on the right-hand tumor. So, focus ultrasound-induced hyperthermia is not only enhancing the accumulation of nanoparticles in the tumor, but also macromolecules. And this is what is happening when we excise those tumors. This is the intensity from the near-infrared labeled antibody, this sacrificed after 5 hours, of the right tumor, and this is of the left tumor, indicating that this is, again, a very powerful technique to enhance the accumulation of macromolecules and antibodies in the tumors. And this is actually, again, my conclusions. The near-infrared probe coupled to lipids or to macromolecules can identify details, can show details about the mechanism of accumulation. And if we can see it, if we can see the drug, we can control it. We can control its accumulation using the focus ultrasound. That's it. Thank you very much.
Thank you so much. All right, we have time for 1 or 2 quick questions. If anybody has a quick question. So I have a quick question. So with your small molecules, it looked like they accumulated and then possibly cleared right afterwards.
They do clear the first round, after the first round of focus ultrasound, most likely because we do accumulate a lot of drug, and the release is rapidly. So we can see, in some cases, a small amount of release. How we can control this? We will have to identify it with the right analytical methods.
Okay. And in the last images, it almost looked like your tumor with the therapeutic ultrasound was larger than the contralateral.
No, it is the accumulation of the drug that it then starts to diffuse around. It's not the tumor that it is larger. They are the same size tumors. Okay. But because we enhance so much, then it's like we are increase so much the concentration that it starts to diffuse into the surrounding tissues.
So for the 3 times exposure, is there any, have you looked at the difference of the overall time of exposure and whether that gap of off is important?
Well, the point was to, if we can see it, the accumulation, we can control it. I mean, we haven't seen any effects or thermal effects because the exposure to ultrasound or the hyperthermia is very short. It's 3 minutes or 5 minutes. It is really short. It is, if we were able to have an animal model where we can do that in a repeated way, then it would be good. Why we have a repetition is to avoid the clearance from the tumors. So in order to control this mechanism, not to enhance the uptake in the formation of the tumor, but also diminish the release from the tumor, the clearance. Yeah.
Question?
Have you had a chance to look at the distribution of either the drug or the antibody in slices of the tumor afterwards and make some comparisons?
Yes, we do. Because with the near-infrared imaging, we don't have to section, or we don't have to, so we can see first within the body. I mean, if the clearance, we can see the drug in the bladder, or we can see the drug in the kidneys as well, and we have seen the drugs in sections, both topotecan, in tumor sections, topotecan and doxorubicin. Heart and kidneys, it's less, because we don't see the signal of the fluorescence.
Not the biodistribution, but the distribution of the drug within the tumor, spatially.
Especially, after release, it is distributed all over in the apart from the necrotic areas. Sorry, the necrotic areas don't have much of the drug. It's true.
I think my comment's actually quite related to that. I think it'll be very fascinating to understand the extent to which ultrasound changes the phagocytosis of any of these compounds. What is the distribution of the cells that actually take up the doxorubicin, and do you get destruction of myeloid cells, the fibroblasts, not just the tumor cells?
Well, we do see, because we apply the ultrasound locally, we do see most of the drug going there. In tissues of liver, for instance, or close by tissues, we do see some of the drug diffused after several inseminations, after several exposures to ultrasound. But we don't see so much drug compared to the tumor and to the treated tumor.
Sorry, I hate to cut off the discussion, but in fairness, let's thank our speaker one more time for the very nice talks. And